Hello, let's check and start. Are we live? Hopefully, yes. Hello, let's check and start. Are we live? Okay, we are live. So we are going to start with hyperparathyroidism. Yesterday we read hypothyroidism, and today we are starting with this. In this session, we are starting with hyperthyroidism. First disease is Graves' disease. Most common cause of hyperthyroidism. Thyroid stimulating immunoglobulin IgC can cause transient neonatal hyperthyroidism type 2 hypersensitivity. Stimulates TSH receptor on thyroid, hyperthyroidism, diffuse goiter, dermal fibroblast, pretibial myxedema, orbital fibroblast, Graves, orbitopathy, activation of T cells, lymphocytic infiltration of retroorbital space, increased cytokines, that is TNF alpha, IFN gamma, increased fibroblast secretion of hydrophilic GAGs, increased osmotic muscle swelling, muscle inflammation, and adipocyte count leads to ophthalmos shown in the image A, often present during stress, that is pregnancy, associated with HLA-DR3 and HLA-B8. Histology: tall, crowded follicular epithelial cells, scaffold colloid. Okay. This is about Graves' disease. Most common cause of hyperthyroidism, thyroid stimulating immunoglobulin IgG can cause transient neonatal hyperthyroidism type 2 hypersensitivity. Stimulate TSH receptor on thyroid, hyperthyroidism, diffuse goiter, dermal fibroblast, pretibial myxedema, and orbital fibroblast, Graves' orbitulopathy, activation of T cells, lymphocytic infiltration of retroorbital space, increased cytokines, TNF alpha, IFF, IFN gamma, increased fibroblast secretion of hydrophilic GAGs, increased osmotic muscle swelling, muscle inflammation, and adipocyte count leads to ophthalmos, often present during stress, that is pregnancy, associated with HLA-DR3, HLA-B8. Histology: tall, crowded follicular epithelial cells, scaffold colloid, toxic multinodular goiter, focal patches of hyperfunctioning follicular cells distended with colloid working independently of TSH due to TSH receptor mutation in 60% of cases, increased release of T3 and T4, hot nodules, hyperfunctioning nodules visualized on radioactive iodine scan, are rarely malignant. Okay. Next is toxic multinodular goiter, focal patches of hyperfunctioning follicular cells distended with colloid working independently of TSH. Due to TSH receptor mutation in 60% of cases, increased release of T3 and T4, hot nodules, hyperfunctioning nodules visualized on radioactive iodine scan, are rarely malignant. Okay. What is toxic nodular goiter? Focal patches of hyperfunctioning follicular cells distended with colloid working independently of TSH. Due to TSH receptor mutation in 60% of cases, Increased T3 and T4. Hot nodules, hyperfunctioning nodules visualized on radioactive iodine scan are rarely malignant. Got it. Thyroid storm. Uncommon but serious complication. Uncommon but serious complication that can occur when hyperthyroidism is incompletely treated, untreated, and then significantly worsens in setting of acute stress such as infection, trauma, surgery. Uncommon but serious complications that occur when hyperthyroidism is incompletely treated with untreated and then significantly worsens in setting of acute stress such as infection, trauma, surgery, present with agitation, delirium, fever, diarrhea, coma, and tachyarrhythmias. Cause of death may see increased LFTs treat with 4Ps. Beta blockers, that is propranolol, propyl thiouracil, glucocorticoid, that is prednisolone, potassium iodide, Lugol's iodine, iodide load, that is decreased T4 synthesis, Wolff-Chaikoff effect. Okay. Thyroid storm, most common but serious complication that can occur when hyperthyroidism is incompletely treated. Okay. Untreated, then significantly worsens in setting of acute stress such as infection, trauma, surgery, presents with agitation, delirium, fever, diarrhea, coma, tachyarrhythmias can cause of death. May see increased LFTs treat with 4Ps, beta blockers, that is propranolol, okay, propyl thiouracil, glucocorticoid, prednisolone, potassium iodide, Lugol's iodine, iodine load decreases T4 synthesis and Wolff-Chaikoff effect. I'm able to connect the dots and understanding it all of the treatment, but there are still gaps in my knowledge. It's okay, we'll continue reading and we'll connect all the dots as we go through all the topics, as we solve MCQs, see patients. Jod-Basedow phenomena. Iodine induced hyperthyroidism occurs when a patient with iodine deficiency and partially autonomous thyroid tissue, that is autonomous nodule, is made iodine replete, can happen after iodine IV contrast or amiodarone use. Opposite to Wolff-Chaikoff effect. Jod-Basedow phenomena. Iodine-induced hyperthyroidism occurs when a patient with iodine deficiency, partially autonomous thyroid tissue, autonomous nodule, is made iodine replete. Can happen after iodine IV contrast or amiodarone use. Okay. Okay, got it. Cause of goiter: smooth / diffuse Graves' disease, Hashimoto's thyroiditis, iodine deficiency, TSH secreting. Okay, for 30 minutes, right? Started at what time? 10 means 3 minutes. Okay, we'll till 7:10 we are going to read. Then we have our gym session. Nodule toxic multinodular goiter, thyroid adenoma, thyroid cancer, thyroid cyst. Thyroid adenoma being solitary growth of thyroid, most are non-functional. Cold on radioactive iodine scan can rarely cause hyperthyroidism via autonomous thyroid hormone production, hot or toxic. Most likely, histology is follicular arrows in A. Absence of capsular or vascular invasion, unlike follicular carcinoma. Benign solitary growth of thyroid. Most are non-functional. Cold on radioactive iodine scan can rarely cause hyperthyroidism via autonomous thyroid hormone production. Hot or toxic. Most common histology is follicular arrows. The absence of capsular or vascular invasion, unlike follicular carcinoma. Thyroid cancer typically diagnosed with fine needle aspiration, treated with thyroidectomy. Thyroid cancer typically diagnosed with fine needle aspiration, treated with thyroidectomy. Complications of surgery include hypocalcemia due to removal of parathyroid gland, transection of recurrent laryngeal nerve during ligation of inferior thyroid artery leads to dysphagia and dysphonia, hoarseness, and injury to external branch of superior laryngeal nerve during ligation of superior thyroid vascular pedicle. Okay. Now, during the ligation of inferior thyroid artery, thyroidectomy surgery I have seen. Okay, transection of recurrent laryngeal nerve during ligation of inferior thyroid artery leads to dysphagia and dysphonia, hoarseness, injury to external branch of superior laryngeal nerve during ligation of superior thyroid vascular pedicle may lead to loss of tenor, usually noticeable in professional voice users. Papillary carcinoma, most common empty appearing nuclei with central clearing, orphan Annie eyes. A. Samoma bodies, nuclear groove, papi and moma, adopted orphan Annie. Increased risk with red PTC rearrangements and BRAF mutations. Childhood irradiation, papillary carcinoma, most prevalent palpable lymph nodes, good prognosis. Follicular carcinoma, good prognosis, invade thyroid capsule and vasculature, unlike follicular adenoma. Uniform follicles, hematogenous spread is common, associated with RAS mutation and PAX8 PPAR gamma translocation. Fine needle aspiration cytology may not be able to distinguish between follicular adenoma and carcinoma. Okay. Most common empty appearing nuclei with central clearing, that is orphan any eyes. Psammoma bodies clear goose. Follicular carcinoma, good prognosis, invade thyroid capsule and vasculature. Unlike follicular adenoma, uniform follicles, hematogenous spread is common, associated with RAS mutation, PAX8, PPAR, gamma translocations. Fine needle aspiration cytology may not be able to distinguish between follicular adenoma and carcinoma. Medullary carcinoma from parafollicular C cells produces calcitonin sheets of polygonal cells in an amyloid stroma. B stains with Congo red associated with MEN2A and MEN2B red mutations. Okay, parafollicular C cells produces calcitonin sheets of polygonal cells in amyloid stroma. B stains with Congo red associated with MEN2A and 2B red mutations. Undifferentiated anaplastic carcinoma. Older patients presents with rapidly enlarging neck mass, compressive symptoms, dyspnea, dysphagia, hoarseness, very poor prognosis, associated with TP53 mutations. Okay. Diagnosing parathyroid disease. Secondary parathyroidism, tertiary parathyroidism, primary parathyroidism, PTH, independent hypercalcemia, hypoparathyroidism. Diagnosing parathyroid disease. In secondary hyperparathyroidism, vitamin D deficiency, decreased calcium intake, chronic kidney diseases. PTH level, calcium level. Tertiary hyperparathyroidism, chronic kidney disease. Primary hyperparathyroidism, hyperplasias, adenoma, carcinoma. Normal between 10 to 50 PTH Pg per ml. Hypoparathyroidism, surgical resection, autoimmune. PTH, independent hypercalcemia, excess calcium intake, cancer, and vitamin D. Okay. Hypoparathyroidism, due to injury to parathyroid gland or their blood supply, usually during the thyroid surgery, autoimmune destructions or DiGeorge syndrome. Findings: tetany, hypocalcemia, hyperphosphatemia. Hypoparathyroidism, due to injury to parathyroid gland or their blood supply, usually during thyroid surgery, autoimmune destruction or DiGeorge syndrome. Findings: tetany, hypocalcemia, hyperphosphatemia. Chevostok sign, tapping of facial nerve, tap on cheek, contraction of facial muscles. Trousseau sign, occlusion of brachial artery with BP cuff. Cuff the triceps, carpal spasm. Pseudo hypoparathyroidism, type 1A, autosomal dominant maternally transient mutation, imprinted GNAS gene, GNAS1 inactivating mutation coupled to PTH receptors that encodes GS protein alpha subunit inactivation of adenylate cyclase when PTH binds to its receptor, end organ resistance, kidney and bone to PTH. Physical findings: Albright hereditary osteodystrophy, shortened fourth, fifth digit A. Okay. Short stature, round face, subcutaneous calcification, developmental delay, lapse, increased PTH, decreased calcium, increased phosphate, pseudo pseudo hypoparathyroidism, autosomal dominant, paternally transient mutations, imprinted GNAS gene, but without end organ resistance to PTH due to normal maternal allele, maintaining renal responsiveness to PTH. Okay. Physical findings same as Albright hereditary osteodystrophy, labs normal PTH, calcium and phosphate. Lab values in hypocalcemic disorder, calcium, phosphate, PTH, ALP, 25 OH vitamin D, 125 OH 2 vitamin D. Vitamin D deficiency, secondary parathyroidism, CKD, hypoparathyroidism, pseudo hypoparathyroidism. Vitamin D deficiency, calcium low, phosphate low, PTH increase, ALP increase, vitamin 25 OH vitamin D low, 125 OH vitamin D is increased. Secondary hyperparathyroidism, CKD, calcium decreases, phosphate increases, PTH increases, ALP increases, 25 OH vitamin D not affected, nothing is there, and 125 OH vitamin D decreases. How this is all happening is, I know I have a little idea, but there is not proper conceptual understanding. There are lots of gap in my knowledge and understanding. I have to learn those, connect the dots, and have an overall conceptual understanding, integrated understanding of all the hormones, all the systems, all the diseases management. So it will be able, I will be able to have better clinical reasoning, and I'll be better able to manage MCQs as well as patients. Hypoparathyroidism, calcium decreases, phosphate increases, PTH decreases, ALP normal, 25 OH vitamin D normal, 125 OH to vitamin D decreases. Pseudo hypoparathyroidism, calcium decreases, PO4 increases, PTH increases, ALP increases, 25 OH vitamin D normal, and 125 OH to vitamin D decreases. Okay, we still have 9 minutes left. Hyperparathyroidism. Primary hyperparathyroidism, usually due to parathyroid adenoma or hyperplasia. Hypercalcemia hypercalciuria, renal stones, polyuria, thrones, uh, hypophosphatemia, increased PTH, increased ALP, increased urinary CAMP, most often asymptomatic, may present with bone pain, weakness, constipation, groans, abdominal slash flank pain, kidney stones, acute pancreatitis, neuropsychiatric disturbances, psychiatric overtones, bone stones, thrones, bones, groans, psychiatric overtones. Primary hyperparathyroidism. Uh, Osteitis fibrosa cystica, cystic bone spaces filled with brown fibrous tissue. Shown in the image a brown tumor consisting of osteoclast and deposited hemosiderin form hemorrhages causes bone pain due to increased PTH, classically associated with primary but also seen with secondary hyperparathyroidism. Stones, thrones, bones, groans, and psychiatric overtones. Okay, secondary hyper. We'll complete hyperparathyroidism and we'll end this session. Secondary hyperparathyroidism, secondary hyperplasia due to decreased calcium absorption and or increased phosphate, most often in chronic kidney disease, cause hypervitaminosis D and hyperphosphatemia, decreased calcium. Secondary hyperparathyroidism, secondary hyperplasia due to decreased calcium absorption and or increased phosphate, often in chronic kidney disease, cause hypervitaminosis D and hyperphosphatemia, decrease in calcium. Secondary hyperplasia due to decreased calcium absorption and or increased phosphate, most often chronic kidney diseases, causes hypovitaminosis D and hypophosphatemia, decreased calcium. Hypophosphatemia in chronic kidney disease versus hypophosphatemia with most other causes. Increased ALP, increased PTH. Renal osteodystrophy, renal disease, secondary and tertiary hyperparathyroidism, bone lesions. Tertiary hyperparathyroidism, refractory autonomous hyperparathyroidism resulting from chronic kidney disease, increased PTH, increased calcium. Okay, so today's session I have read all the points about. We read hyperthyroidism and the parathyroid tissues. What is tissues? Parathyroid disease. Tissues plus disease. Tissues. What words I am making? Hypoparathyroid, thyroidism, and hyperparathyroidism. Yes, I have read this, but it's showing my there. I'm not able to connect all those because I haven't been in touch. So constantly I must have in touch of all of these points. I must develop my basic conceptual understanding of integrated systems, revise it, solve questions. This is exciting, and I'm learning. I'm going to use this knowledge to treat patients. Yes, I'm liking this, enjoying this, but the thing is, we need to have patience. We need to come and sit and put in the effort, start understanding, start correlating, and start deriving that joy from this. So it will be functional. I will come again and again, and I will build on it. If not, what I will do, and what most of us will do, is spend time on social media entertaining ourselves, but that will lead us nowhere. So that's why this effort of mine, I am reading it live. This will keep me consistent. We are going to build on this live reading experience as my knowledge, conceptual understanding grows, and the more better I get in this streaming setup and all. There are more things are coming, but this is our starting point, and from this we are going to build on it. So yes, this was our session for now. Hopefully we'll do one more session today. Right now it's time for me to go to other aspects of my life. I'm going for gym session now. Yeah, we are live for now more than 30 minutes, and 30 minutes was our target. Not actually our target is, minimum 45 to normally 45 to 45 minutes to 1 hour is our target. But if we can't do that, at least 30 minutes we have to do, and that's what we have done here. And hopefully we want to have as many sessions as possible, 45 minutes to 1 hour in a day. So yes, we are on it. To build momentum, we have to start with at least one session, and we have done it successfully, so we are happy, and we'll call it a session.